Welcome to this session of our virtual midwifery week that is focused on the expanded role of the nurse midwife and ways that you can, as a nurse midwife or a nurse midwife student, consider expanding your role so that you can best meet the needs of your clients. So I want to introduce you to our panel today. We have a wonderful, esteemed panel here, and Heather Schlosser is an assistant professor and the interim program director of Frontier's Psych Mental Health NP program. She has been on the faculty at Frontier since April of 2012 and has authored several book chapters with a psychiatric focus as well as alternative care models in primary care. She is both a family nurse practitioner and a psych mental health nurse practitioner. So welcome, Heather. Thank you for being with us. Give a little wave so everybody knows who you are, Heather. There's Heather. All right, next up we have Dr. Julie Paul. Julie is a DNP midwifery graduate from Frontier, and she finished her midwifery in 2006 and her DNP in 2011. She currently is a hospitalist at South Shore Hospital and is the co-director of the midwifery program there. And we welcome you, Julie. Thank you for being with us today. You want to give a little wave? Yay. And last but certainly not least is Rhonda Arthur. Dr. Rhonda Arthur completed her doctorate in nursing practice at Case Western Reserve University. She is a nurse midwife, a women's healthcare nurse practitioner, and a family nurse practitioner. She has worked in rural primary care and is currently serving in rural and underserved communities. She has also taught at Frontier Nursing University for 10 years and was program director here at Frontier for 5 years. And I am the facilitator today, and my name is Tanya Nicholson. I am the Associate Dean of Midwifery and Women's Health at Frontier Nursing University. I'm a certified nurse midwife and a women's healthcare nurse practitioner, and I'm so pleased to get to share this time with you today. So I'm going to get started right away with a couple of questions. I'm going to start with you, Rhonda. You have a lot of titles. You're an FNP, a women's healthcare nurse practitioner, and a nurse midwife. So I want to ask you, what prompted you to get all of those different certifications? That's a lot of money you spend keeping those up to date. And what do you think that actually means in your practice?
Well, so I'd like to have a much better answer, but originally I wanted to be a nurse midwife, and that was my love and my dream. But unfortunately, I live in southwestern Virginia, and when I completed my certificate in nurse midwifery, the political climate here for nurse midwives to be able to practice was terribly, terribly unfavorable. And there was a medical community working very hard to keep nurse midwives out of practice. So I added WHNP and then FNP in order to actually break into the current and break into practice. Now, I am happy to say that that has changed and is changing, and now we currently do have nurse midwives in practice. And a lot of the women here wouldn't get a lot of prenatal care, and a lot of the OBGYNs didn't want to treat them, like if they had an ear infection or a bladder infection. And it was interesting that they didn't want nurse midwives at the time in their practice, but they would send their patients to me in primary care for me to treat their sick pregnant women. And even like neurologists were calling me for the pregnant women to talk about seizure meds and stuff, which just blew my mind. That, you know.
So you know what that says to me is they were seeing the value of the midwifery side. They knew you knew about pregnant women.
Yeah.
But the political climate was not quite ready yet. So you helped to pave the way.
Yeah, and so it has changed and grown. And then you know, I really, really personally love the idea of the small family practice clinic where you can see the pregnant woman, treat the pregnant woman, you know, deliver the baby, treat the baby, follow the child, you know, throughout its life, and then bring dad in too. And so that's been, you know, one of the, I guess it's kind of fun to, you know, to have that little bit of a broader scope and to be able to take care of everybody and get a bigger picture. I've really enjoyed that.
It also sounds very similar to our history with Mary Breckenridge and the way they cared for the whole family. It was not just care for birth, it was care for the whole family. So thank you. Heather, I want you just to tell us a little bit about the role of the Psych NP and why you think midwives should consider this addition.
Thank you, Tanya. The role of the Psych NP is really to look at the holistic approach, a little bit like what Rhonda was just talking about with the bigger picture. So caring for families across the spectrum. And the psychiatric NP is really looking at things from a holistic point for individuals, families, communities, groups who really struggle with mental illness, from the everyday kind of run-of-the-mill up and down, depression, anxiety, to the more severe mental illness, which psychiatric NPs are prepared to care for across the spectrum. So children, adolescents, adults, women, pregnant women, elderly, and really take a step back and look at that bigger picture and care for them in a collaborative, holistic way. And why do I think midwives should become psych NPs? I think that midwives are really in a phenomenal position to target mental health issues in women. So as we know, there is a huge shortage in mental health care providers. I think that the last statistic I looked at said that there were 4,000 areas in the US that have a severe shortage of mental health providers. And we know that women's health centers are actually growing. So many women, this is their only touch point for healthcare. It's the only opportunity for them to get in and for somebody to intervene and ask, how are you? How are you doing? What's happening? What's good? What's bad? What's working? What's not? It gives certified nurse midwives such a huge opportunity to get in and help to evaluate that. I believe half of women who suffer with clinical depression never seek care. I think that was one of the most recent stats that I read. So if their only touch point is when they go in to see their certified nurse midwife, who they adore and trust, that is a huge opportunity for them to be able to expand their scope, to be able to deal with the mental health issues, the major depressive disorders, premenstrual dysmorphic syndrome, postpartum related hormone changes that result in mental health issues. Already certified nurse midwives are so intimately involved in that care, and this type of a program and certification only expands that, so they can really take care of that comprehensively within their practice and to educate others about the mental health issues that women really struggle with. There's a lot of trauma in women that I think certified nurse midwives could really target in such a healthy way, as well as substance abuse. I am part of a Subutex program here. I work with a women's health psychologist, and we do the Subutex program for pregnant women. And we're really blessed to have that in our clinic and have that outreach, but there's a lot of communities that don't have that. And I think that's another place that certified nurse midwives could play a huge role in the opioid crisis and the rising use of substance abuse in women. So I think there's a lot of areas that they could make a huge difference in. And I don't think it has to be, I'm a certified nurse midwife and now I'm going to become a psychiatric NP, so I'm leaving midwifery. I think it's the marriage of the two that is so sweet and so amazing and can just really target a population that is not accessing care the way they should be able to.
Thank you, Heather. And I saw Julie, you're nodding your head down there. And a little birdie told me that you are going to add Psych NP to your current role. And so I want you to tell everybody a little bit about your current practice and how you're using your DNP, but also why you're interested in adding the Psych NP.
Sure, thanks. So 5 years into clinical practice, I realized there were so many different issues that needed change. And I just had no idea how to go about that change. So I went and got my DNP to be able to do that. And my DNP project was midwives and triage. And that opened up a whole host of avenues that I didn't even know existed. So my project went on to be the stepping stone to the labors program that we now have at South Shore Hospital. It also allowed me to publish my results and share the results. I have since gone on to do other quality improvement projects within my institution. For example, creating a way to delay admission to the birthing unit to help lower our C-section rate by creating the first early labor lounge in the United States. And so, yeah, that's pretty cool.
Okay, I just have to say that is very cool. Keep going.
So we are also part of the Reducing Primary Cesarean Collaborative with the American College of Nurse Midwives, and to help lower our C-section rate. And so that project has taken on a whole new dimension as well. So my DNP has helped me to feel confident to be able to go through these quality improvement projects. So with that being said, I also work in a clinic 1 day a week, and I see tons of women that suffer from postpartum depression, anxiety, and as Heather said, the increase in opioid use. So my goal is to create a program once I go through the Psych NP program, is to come back into my community, and I've made a proposal to my hospital to create an outpatient postpartum depression clinic / opiate addiction clinic for women in our hospital setting, replicating the system that they have at Women and Infants, where they keep women in their community. They are allowed to bring their baby with them to the hospital, and during their counseling sessions, they are able to learn about lactation and infant massage, and then incorporate that into their postpartum depression clinic. Right now, we have to ship all our women because there's no services in our area, or there's such a lack of services. And nobody knows how to do shared decision making with women on the proper medication for antidepressants or benzos in labor or in pregnancy. And so I really want to be well-rounded and be able to offer these services to women in our community and keep them with their babies in their home setting and in their, so they can go home at night but still receive the services they need.
Mm-hmm.
That sounds like such a wonderful integrated way to, women, we don't have boxes. We don't have our mother role, and we're just a mother today, and we're just an employer today, or an employee, and we're just a sister another day. All of our roles are mixed up, and so to be able to take the concerns and issues that the woman is facing with depression or anxiety and still show her how to function within her real life with her baby with her, and that is a wonderful way to approach this. That's exciting, Julie. I can't wait to hear how it goes once you're done.
Well, it's really cool the hospital's on board with supporting this program. So anything that we can do to make this happen, because they recognize the opioid crisis and the postpartum depression, the psychiatric conditions. And we have people lining up in our emergency rooms, and they're just, so let me give you an example. One time when I first was in clinical practice, I had this patient woman who I delivered. It was the very first person that I delivered as a new grad midwife, and we had developed a really close bond. One day, like 3 weeks after she gave birth, her husband called me and said, "My wife's not making sense. She's walking the halls and she's just kind of yelling random words, and it's really scaring me." I'm like, "Okay, we'll come to the emergency room," because that was really the only place that I could have her come. So she came to the emergency room, and I went down. At first she recognized me, but was really acting erratic, was getting really psychotic. Within 4 hours of her arrival, she was in 4-point restraints. She didn't recognize myself, her husband, or even that she had had a baby. We had to transfer her into Boston, and where she got intense therapy. But how nice would it have been if she could have stayed in her own community, felt comfortable, and got treated with her baby. They were separated for over 2 weeks. And so that's what's been kind of in the background of why I really want to pursue this.
And what a wonderful way to take your relationship. I mean, she already trusted you. So to be able to continue in that relationship and that role of trust into those most intimate and scary things like psychiatric issues, to be able to provide, really quality and complete care. I have had similar issues, Julie, where, we see clients and I'm comfortable starting like a baseline med with them or a first line med. And as we find, or if we find that that is not adequate, I don't have the resources in my community to easily get them in. Very often it's months before they can see anyone who can help them. And that is maddening. And you're right. Then the only resource is the emergency room. And then they have to be at such a point that they need to go inpatient. So we've missed all that opportunity to intervene prior to that critical and acute time. So it's frightening. Heather, can you tell us a little bit about Frontier Psych NP program? Heather, you're still muted.
Can you hear me now? Thanks. So the Psych NP program at Frontier essentially at this point is 2 tracks. There's a postmaster's or postgraduate certification program, and then there's a postmaster's or postgraduate certification program with a DNP companion program. So folks can choose to come in and do the postmaster's program, take their certification, move along on their way, or they can continue on and get their doctorate after, which I would strongly encourage for everybody to do, to be the ultimate advocates of not just become a psychiatric NP, already having been a midwife, but be able to get that policy change in place so we can all do programs like Julie was talking about, like I'm talking about. So you have the skill set to be able to move forward and help with policy change, advocacy programs, and really build your community up. Because as we know, even one person with a certification can't change everything in that community, but we can if we go on to bigger and better areas to really try to grow programs and look for funding and allow for greater access for patients. The program is really looking at educating the psychiatric NP from an integrative approach. So again, you're not a standalone. The idea is to learn how to work as a team, learn how to work with your partners, with your peers, to really put your patient-centered approach, so mom, baby, family in the center, and really rally in all of the community-based resources and providers, both inter-community and extra-community, to be able to rally around patients and families from having the background of pharmacological intervention and non-pharmacological intervention, both of which are equally important across the board. So our goal is really going to be to educate people around both sets of interventions. So looking at pharmacologics and non-pharmacological interventions, different types of theories of therapy.
That's very attractive, especially to midwives, I think, because very often we attract a clientele that is interested in exploring non-pharmacological interventions first. And so that's exciting to hear that we're looking at the approach from an integrative standpoint.
Absolutely.
Rhonda, can you tell us anything else about the importance of family nurse practitioner role in combination with the midwifery role?
Yeah, I can speak a little about it, but first I just want to say the whole idea of the Psych NP, particularly in my rural area, and I'm sure many other rural areas, the fact that we all as midwives or healthcare providers do screening on our patients. And so I screen them, I identify problems, I see something that they need, and then golly, like sometimes it's 6 months before you can get someone in to see, into care, and meanwhile they deteriorate or else they have to go in on an emergency basis. So I really commend everybody on that idea and expanding into the psych program. I think that for our patients in general, it's going to be pretty amazing. I remember in my community having a mother who had twins that ended up, having to be hospitalized away from the twins for quite a long period of time. And just the fact that the efforts we went through to get her help in a timely, it was just nearly impossible to find any good help. So I'm glad that we'll have a few more resources, in the future with, the expanded programs and maybe more midwives and nurse practitioners picking up that certification. So I think that's exciting. As far as family nurse practitioner, adding that on, for me personally, I have really enjoyed being able to also, like I said, treat dad and treat the family, because it gives me a bigger picture. I find that I just understand and know the family so much better being able to treat the whole entire family. But some of my favorite things are that right now we have another midwife and a women's health nurse practitioner that also work at our local health department. But I find that that I'm called out more often and I get more scheduled time because I'm able to do the well child visits. We don't have that many anymore, but when children come to our community and need a well child visit to get into preschool, I'm the only one in the health department that's able to do that for the family to keep that child in school. I tend to work almost all the sexually transmitted infection clinics because we see males and females, and the women's health, even though it's within their scope for partner treatment and stuff, I seem to get that, and I believe that maybe I'm more comfortable than my other two colleagues in that area. But one of the best and favorite things that I get to do is that here locally, we're a very rural community. We have one stoplight, and the beauty of my community is how rural it is. Well, there is a camp nearby that brings urban children who don't get any country exposure up to the county, where the children get to garden, learn how to swim, which I just personally believe is so important. They do biology studies in the creek. They learn to play basketball, all sorts of outdoor activities with the kids. And because I'm a family nurse practitioner, I'm able to give free camp physicals to all the children who could not afford a physical to entitle them to camp. And sometimes it's just a camp physical keeping those kids out. And I have to tell you, of all the things I do, that may be one of the most fun things I do. And the particular organization also, so you worry a little bit, well, what if you identify a problem there? That organization, like if they need glasses or if they need, say, a cardiology follow-up, that organization helps them get it. But I get to be on the front line to do the physicals and identify it, and then the organization takes it from there. And just the idea that because of my little additional training, I can give that away and get a lot of kids outside playing and active and learning to swim. And that's really a rewarding part of my job.
Well, you know, one of the major visions that our very own Kitty Ernst has is that within the birth centers that we have nurse midwives who are also FNPs, or that we're all working together so that it's a family birth center. In other words, we can provide all of that care, including the birth, and then the care for the whole family. Like, what a wonderful continuum for the family to have these trusted providers be able to do all of that. Julie, do you have anything you'd like to add?
I'm just going to say that I really think it's important to expand your role because, like you said, women cannot be boxed into a certain category, and they all come with families, they all come with different conditions. And if you can understand the entire picture, I think we can provide better care that way. And with where healthcare is going in the future, we need to be that. We need to be the solution for healthcare cost, for patient satisfaction, for all of it. And if we need just to rise to that occasion.
Thank you so much. I think that was a great summary statement, Julie. And so on that, I'll just finish by thanking you guys for being here with me. And for those of you who are listening to this, I hope that you're encouraged and inspired, and that what you see for yourself is a future that includes not only your pregnant women and their babies and their births and the care of that woman, but the care of the entire family, and being able to care for that woman in her community, giving all the services she needs, and being the cornerstone for the woman and the family's health care. So thank you all so much. Thanks for being here, and thanks to our panel today.